Hello, everybody. Um, Here are the sociodemographic features of and this is the method. Uh, and these are the results. So, talking about the results, of course, this absence.
Here instead you can see our second case series considering the use of intranasal esketamine as a novel antidepressant treatment recommended for treatment-resistant depression. We recruited 7 patients, 3 males and 4 females, in Santa Fe Lettura Hospital from March 2021. These patients were affected by a major depressive disorder or bipolar disorder and were diagnosed with a major depressive episode according to DSM-5 criteria and resistant at least 2 antidepressants. From these slides, you can also see the current treatment of the patients, SNRI, SSRI, mood stabilizer. As we all know, esketamine nasal spray device is a 28 milligram, and we use one device if the age of the patient is more than 65 years old, instead 2 devices, so 56 milligram if the age is less than 65 years old. Administrated intranasal esketamine twice a week for the first month, once a week for the second month, once a week or once every 2 weeks for the third month. Psychotropic effects were evaluated by CADS from the beginning of every administration every 20 minutes until the end of observation 90 minutes. So also we detected vital signs every 20 minutes like blood pressure, and we made a clinical evaluation before and after each administration, different weeks of the treatment, using different scales like Hamilton D, Hamilton A, BDI, Young, and Beck SSI. So here you can see the clinical results of our experience using intranasal esketamine. 4 patients had an improvement in depressive symptoms. 3 were remitted. Some had a final score in the Hamilton D less than 8 points, and 1 had a clinical response. From the graphic, you can see the Hamilton D score the patient had during the treatment. 3 patients out of 7 withdrew actually the treatment. 2 for perceived inefficacy, 1 for personal reasons. So CAT scores, what about it? Dissociative symptoms were not present at 90 minutes set point in every session. Most of our patients were perfectly fine at the end of every session. Sometimes it happens they were sedated a little bit.
A subsample of 4 patients underwent 2 7 minutes resting state fMRI scanning using a 3 Tesla scanner. Images were acquired at the baseline and after 2 months of treatment. The data were preprocessed using a Con toolbox, and we perform as second level analysis a ROI to ROI approach, considering 132 regions of interest. Analyses were also corrected for multiple comparisons. Results show a significant decrease of functional connectivity between precuneus and brainstem. This is in line with literature of ketamine administration, showing a reduction of functional connectivity of posterior default mode network, whereas we also detected an high integration between sensory, frontoparietal, language, and silence networks. In particular, our results are also in line with previous literature on major depressive disorder and ketamine administration, considering that we detected an higher functional connectivity of striatal cortex and of hippocampus.
As we concern, the use of esketamine in our TRD patients showed good effectiveness and tolerability. So, for us, it could be a new option of treatment for TRD. We can ask ourselves what to do next. Randomized controlled clinical trials are needed instead to confirm our findings.